We had a good, base now. I'm going to give you a little more practical aspect. I've been doing myopia control since last 20 years, and I'm an optometrist, so we see more of a non-surgical patients. So there are a lot of advancement as far as the atropine, the spectacles, contact lenses, orthokeratology. There are so many gadgets available now if you are serious and if the parents are serious. So
change the next projector.
Folder empty. So as far as the atropine is concerned, it is available 0.01% in India. But there are a lot of studies now showing that whether it's a placebo or it is working really. If the disease is different, can you still continue with only one dose? No, right? You have to understand what is the myopia progression risk, and accordingly you can adjust the dosage. So there are a lot of other studies. The clear study shows that 0.01%, 0.025 and 0.05. 0.05% is most effective in most of the cases, but what in real practice what I do is if it is less than -3, you start with 0.01%. If it is 3 to 5, then 0.025. It is not available in India, I know, but what you can do is you can double the dose. The same dose, you wait for 5 minutes and again put 0.01, or you can do morning and evening. And if you know the myopia is more than -5, you try 0.05%, and that is one of the methods that we use in the US at least. Here still it is not available, but I think Entod is coming with 0.05% soon. It's under trial right now, so within 6 months hopefully it should be available, and you have more variety of atropine to use according to the patients.
Slides,
Second important thing which I would like to highlight is the whatever myopia progression is happening is because of the myopic defocus and hyperopic defocus. The hyperopic defocus will continue the myopia progression because that is how the emmetropization happens. And if you can convert that peripheral hyperopic defocus to myopic defocus, that sends signal to brain to control the progression of the axial length. Most of important thing is the axial length that you are supposed to control than refractive error. Refractive error is what you see because we don't measure axial length all the time, but if nowadays you have to actually document the axial length to understand and whether your control is happening or not. So let us go with the slides now. I have no financial interest in the talk. So eye growth happens visually. As the child is small, like 1 year or so, he is hyperopic, and as he grows, it becomes emmetropized by the age of 4 to 5 years. And what happens basically is the peripheral defocus, which is the signal that tells the brain how much eyeball should grow. As the previous speaker said, there are a lot of animal studies. They have cut the optic nerve and still the progression happens because the peripheral retina is responsible for the growth of the eye. The moment you put in a spectacle, what happens is the wavefront which is there, which is focusing on the retina, the peripheral defocus happens, whether hyperopic or myopic. In most of the time it is hyperopic, and that sends signal to the brain to increase it further to get that thing on the retina. So when you prescribe a single vision spectacle, you are actually contributing to the myopia progression. Sorry, this may sound a little odd, but this is what is the fact. Because the moment you correct it, it is going to shift that focus more. And that is why the people, previously we used to think that under correction, we can give under, but even if under correction, it doesn't happen. So the response to the eye growth is because of the chromatic aberration, the light basically, and the optical defocus. So how to get that myopic defocus? At the same time, patient has to see clearly. So you need at least 2 focal points. So that's why you came with those bifocal spectacles and other modalities. They do work, but not up to the mark. So orthokeratology has been shown consistently that it works almost 84% myopia control, and if you combine with atropine, it is almost 90%. So in orthokeratology, what happens that peripheral, the reverse curve which is there, that causes +6 diopters, and that is what the myopic defocus happens at the peripheral retina. There are a lot of animal studies, as I said, they have actually tried and controlled the myopic defocus, and they have seen the growth of the eyeball in that particular direction halts. So that is a very well known proof. There are a lot of animal studies. Even in monkey studies, they have used the same monkey, one eye, they created a hyperopic like plus power, and other group of monkeys they put minus. So wherever they have put minus glasses in one eye, that eye progressed further than the normal, and plus eye did not progress. The control was the same animal's other eye. And funny part is, for the animals, when they corrected it both eyes, again it got normalized. There are 120 genes responsible for myopia. So there are a lot of other variants which are playing in this arena. But if you can strongly focus on the optical part and of course the pharmaceutical part, you can very well control the myopia progression. So bifocal, multifocal lenses, multifocal soft contact lenses, and orthokeratology along with the atropine. Same thing, I'm not going to re-emphasize. So that is what you are trying to do. You are trying to get that hyperopic defocus to myopic defocus. Now here I want to say why we are talking about outdoor activities, not to close the gadgets and everything. Actually gadgets, they are designed, they will not emit as much UV light as the natural daylight. It is 0.01% of the sunlight. So it is not a factor actually. The factor is you are seeing a close distance, any object, reading, writing, or any close activity that you do. So what is happening is, when you do a close activity, when you look at distance, the image shell is forming exactly on with the contour of the retina. The moment you come closer, the focus is on the retina, but the peripheral image goes out of the retina. That is hyperopic defocus, and that is what is causing the myopia progression. So any close work, so you have to do close work because you have to study and all. So try to keep it more than 12 inches to 13 inches. And in China, even they have put some barriers so that the child cannot go further. So the myopic defocus is responsible, it is because of the hyperopic defocus happening at the peripheral retina. So now how to get that inside, that is to create a myopic defocus. So multifocal soft lenses, this is so far the only multifocal contact lens FDA approved. It is available in Canada, still not available in the US market as freely, but slowly it will happen, everywhere it will be available. So what you have to use is a multifocal. This is just a different design. So there is a central power, then there is a plus power, then again distance and plus, like that. And there are so many other companies slowly coming in the market. But in India, you can at least, as I said, spectacle is one of the major cause of creating that hyperopic shift. So use some kind of contact lenses that will at least reduce that hyperopic shift at the periphery. If you can use a multifocal soft lenses, again I know there is no single, the multifocal lens you need is a center, distance and periphery near. What multifocal soft lenses available in the market are for presbyopia. But surprisingly they also work in some extent. So you can use those. Why they work? Because the contact lens sitting on the center of the cornea, which is little bit displaced away from the visual axis, and that again it causes the peripheral plus power dose at the some part of the retina, and that contributes to myopia control. You need minimum plus 3.5 diopters to get the hyperopic defocus shifted to myopic defocus. It has been studied, there are a lot of papers available. So anything less than 3.5, it is you are just trying to reduce that shift, that's it. But if you can get anything more than 3.5, it is fantastic. If you have a way to customize, get the lenses from somewhere, so that is what you are looking for. Atropine combined with the spectacles or contact lenses or whatever, the optical stimulus will work fantastically. And as I said, 0.01 is still of course there are a lot of studies by Dr. Jetani and so many Indian authors. It says it proves, but if you can increase it to depending on the myopia risk. So combined therapy works. Saying the myopia risk, how do we know? So Dr. Maskati, Jethani and myself came up with this calculator. It is available online. So what you do is you take all the factors, what the previous speaker was saying. It is not only the refractive error, the parental myopia, work environment, how much time spent outdoor, at what age you got the myopia. Earlier you get the myopia, there is a high risk that the child will become high myope. So start early, and depending on that risk factors, you can plan your myopia control strategy, whether to give 0.01, 0.25, 0.5 and any other modalities of optical stimulus. So start early, consider myopia, parental myopia, time outdoors. Though it is said the outdoor timing is only responsible for the onset of myopia, but in reality, if you still press that child to spend more time, 2.5 hours, what happens is they spend less time on near work, and that will again contribute to the control of the myopia. Lighting conditions, I tell my parents and children is not to do any close work after sunset, which is impossible, but because you need dopamine as well as melatonin to control the whole body functions. So when you continue reading, writing after sunset, your dopamine formation continues, and that doesn't give enough time for melatonin to repair your body, and that is one of the mechanisms. So multifocal soft lenses, orthokeratology, and combined with low dose atropine. You have to monitor the axial length. Most of your ophthalmologists, you have access to the axial length measurement. So measure that and monitor the axial length, because that is what is causing the problems of high myopia. As you get a stretch on the eyeball, your there is a high risk of glaucoma, cataract, retinal issues. So you have to control the axial length. Now I am going to go a little more deep, because this is actually practical and you can actually do it. So orthokeratology, basically they are RGP contact lenses. They are FDA approved for overnight use under the closed eyelids. No other contact lenses are, you have to have minimum 84 DK material so that you can use it under the closed eyelids. So what it does, it reshapes the cornea to give the correction. But in myopia control, we are not interested in that reshaping of the front, the epithelium center. The periphery reverse geometry, what you get is what is actually helping you to control the myopia progression. That 50 microns of epithelium, you are causing a pressure and little space there. So the epithelial cells will swell at the periphery and will shrunk in the center, and that will cause the correction of the refractive error. And as I said, it is that reverse curve which is causing that plus power, and that plus power now can be increase or decrease if you know how to design the lenses. If you talk with the lab, they will help you. And second, importantly, you have to have the smallest optical zone or treatment zone, so that it should be less than a pupillary zone. Then you are going to get that myopic defocus at the periphery. Topographer, all these instruments are available, image capture. I'm not going to go detail in this. You have to analyze with the fluorescein patterns. Actual subtractive maps will give you how much is the effect. That plus power dose, what you are seeing, is what is causing the myopia control. And I'm going to take another 2 minutes extra. So all these reports, you will understand whether your treatment is going according to your requirement or not. And while doing all that thing, if there are issues that you can identify with the analyzing the reports, whether lens is sitting up, down, or it is not giving adequate fit, so you have to modify the fits. Most of the 40% of the contact lenses that we fit in Ortho-K are now toric lenses, because surprisingly a lot of children have astigmatism. We still don't know why, but it is there, and the toric lenses helps correct that. And they are little expensive than a spherical correction, but whatever is required is to be delivered. And these are the basic Bull's map, which is what you're looking at. Smiley face, that means lens is going sliding down, because you are seeing the patient in the daytime, whereas the lens is acting in the night, so you don't know what is happening. The lens is going up or down, but your topography map will tell you what is happening. If the lens is riding up, you will see the frowny face. So accordingly, you can adjust the diameter or the curvature of the your Ortho-K lenses. And basically, you have to have a smaller optical zone or a smaller treatment zone. Then only it will work in the myopia correction. If you are doing the Ortho-K for adult, you have to get maximum treatment zone or optical zone possible, more than 6.5 or so, and that will help you with the full correction. What you are trying to control is the axial length. So we call it a plus power dose. When we started fitting Orthoke, we never know that it is going to help the myopia control, but surprisingly, after seeing so many patients over a period of time, we realized the children who are using Orthoke lenses surprisingly is not progressing further, and that is how we then now we modified and got that thing. This again I'm not going to emphasize, it is available, so you can use a combined therapy with some kind of a optical treatment. It is easy and simple to order Orthokeratology lenses, just full refraction, K1, K2, horizontal visible diameter and topography. The lab will give you the lenses. And if after 1 week, if you see there is any change in the topography that asks you to modify the lenses, you should send that map to the lab and they will modify the lenses. Care and maintenance is most important in these cases. All the lenses has to be stored in hydrogen peroxide system, otherwise you are asking for infections and other things. I'm almost done, 2 slides more. So there is still no Indian manufacturer, but these are the lenses available from the US. So use some kind of a optical stimulus along with the atropine. That way you can control the myopia, and as the previous doctor suggested, lifestyle modification, all the fruits and healthy habits of living. Thank you very much.
Thank you, Mr. Chandrashekhar Chawan. I would like to call upon the next speaker, Dr. Prachi Agashe, to speak upon side effects of atropine eye drops and contraindications of myopia control therapy.